without further ado, I would love to turn it over to Dr. Rocco.
Hi, everyone. And thanks so much, Nate and everyone, for putting this together and for inviting me to talk at it. It's a great honor. And thank you so much, Anna Grace, for telling your story, which is unfortunately to me an all too familiar story of patients running into providers that are they're unaware, or these are supposedly rare diseases and complex diseases. And we just, to reemphasize your point, we just don't know enough about them. And we need to do everything we can to learn more about them. And I think what we're working on with Anna Grace and many others is to learn everything they can about one and each person, because this is different in everyone. And I'm going to talk a little bit about some of those things today and how we're trying to address them. So thanks so much, Anna Grace, for telling your story and highlighting such an important thing that we need in this field. To introduce myself, I'm Joe Rocco. I did infectious disease immunology fellowship at the National Institutes of Health here, and then stayed on as a new clinical investigator, actually, over the last several years now, with an entire program dedicated completely to studying H and HLH alone. I don't know if I'm the only person who only sees HLH patients, but there's definitely not many of us. And the goal is sort of exactly what Anna Grace was highlighting, to really figure out every single patient and optimize therapy on a personalized basis for them. And people ask me how I got into this field. And I think if I look back on it, it's very much that I ran into patients that were very similar to Nate and Anna Grace throughout my training and residency and fellowship. I remember so many patients. I remember all their names. I remember all their faces where HLH was considered in the differential. It was strongly thought that it was contributing, and there was a uniform response when we were trying to figure out what to do for it. And every single person said, we don't know. We go to oncology. They say, well, it's probably that, but we don't know what to do. Go ask rheumatology. And rheumatology would be like, yeah, that seems like that could be it, but go ask hemonc or infectious disease. And infectious disease would say the same thing. And it went around in a circle. And unfortunately, for the most part, all of those patients who were not old patients from 10 to 50 died. And that was extremely disheartening, but also I felt like that should not be the case. There's a quote that one of my attendings said to me, which I was angry about, but I was like, I want to study HLH. And they said, well, every patient I've ever met with HLH died. I was That seems like a very good reason that someone should study this. And a lot of that was my motivation to pursue this further in fellowship, and then meeting some very influential physician scientists at NIH, where I brought up these similar things. And I said, so many of these patients die. Shouldn't someone study this? And Steve Holland, who's the head of the intramural program at NIAID, he said, yes, they should. And he's like, you should do it. And I pretty much just never looked back from there. So to go into HLH a little bit, this is hemophagocytic lymphohistiocytosis, not the easiest histiocytosis to say, although it has good competition. It's by far the most inflammatory, sometimes called hyperinflammatory syndrome of all the histiocytoses. These patients can become so sick so quickly, and identifying and recognizing it is not easy. The way that I like to describe it in its simplest form is, you come into an infection, you have to turn your immune system on to fight that infection. But when the infection goes away, you have to turn your immune system off too. HLH patients, in the simplest form, lose that ability to turn their immune system off. And so they just keep activating it and activating it and activating it in this severe and life-threatening inflammatory spiral until they get multi-organ failure. And this can happen at different rates. It can happen very fast. It can happen slower. And a lot of that contributes to why it's hard to recognize. So people ask, a lot of these histiocytoses are rare. True primary genetic HLH, which almost always presents, at least in the literature, in infants less than 2 years of age, is supposedly only 0.5 in 100,000. That's pretty rare. Now, my sort of counter to that is, how many adults with HLH have we performed genetic sequencing on? And the answer is preciously few. And Anna Grace is a quite example of that. No one really thought about it. And then when they did think about it, they got an answer that they couldn't explain, but certainly seemed like genetics were contributing. So we can't say everyone presents under 2 when we haven't looked at anyone else. So I think this is a much more common disease than anyone completely realizes at this time. And I think, and we're going to be able to show that more and more. Where are the misconceptions? I think patients with HLH, it often develops in the setting of a different disease. So a lot of these patients will have cancer, or will have an autoimmune disease or an immune dysregulatory syndrome. They may have an infection that sets it off. But there's lots of patients in the world that have cancers, that have autoimmune diseases, and they get infections, and almost none of them go into HLH. So there has to be something else contributing there that we don't really know yet. And I think because people think it's rare, we don't think about it as much as we should. And so some of the things we're doing is working on finding better diagnostic criteria. The question is, well, what makes you recognize HLH? What should patients know, and families know if their family members could be involved? People think it's rare. There's criteria out there that are, again, kind of designed for the infants with this sort of pure genetic HLH. They're not always applicable to adults. And actually, in the adult HLH world, you get at the Histiocyte Society meeting later this month, you get a bunch of HLH experts in a room and you can watch them duke it out about what they think the right criteria is. There's no agreement. I personally think to solve one of the major problems, which is an under-recognition and under-diagnosis, we need to loosen the criteria just a little bit and make it so people think about it more. So my sort of criteria that I teach residents and fellows and how they should recognize it is fevers, persistent fever, high ferritin, and falling blood counts. If your blood counts are going down, you're having fever, your ferritin is increasing, and people don't know what's going on, HLH is on that differential in everyone. And then there's the question of how do we diagnose it? But there's another potentially even more important question quickly saving these patients, and that's, do we have any markers for how severe it is? And I think that, especially in the adult world, although I think it will apply to peds too, we have a study coming out very soon where one of the new markers we've looked in a huge cohort of patients, over 100 HLH patients, this marker of CXCL9. Now, I don't know if you've heard of it just yet, but this is a surrogate marker of a very specific cytokine called interferon gamma. If anyone's perused any of the medical literature about HLH, you know, the macrophages are clearly involved and activated, but the T cells are the ones that drive the disease, and they drive it by producing way too much of this interferon gamma. And fortunately, this CXCL9 marker is a perfect surrogate marker of interferon gamma activation. So you can actually tell probably if a patient has HLH or not, but you could certainly tell how severe it is almost with this marker alone. And that's one of the things we're going to show in this paper that's coming out soon. And so now we're trying to spread the word about this so other people are using it. What we've actually also been able to show, we didn't get this done in enough time to present at Histiocyte Society, but we will be presenting it at ASH, and I'm jumping around a little bit, is this CXCL9 marker also predicts patients that will respond to very specific targeted therapies like imipalimab, which is the interferon gamma blocking agent. Well, this makes complete sense. We have a marker that says your interferon gamma level is too high. You can give the imipalimab, dampen down that interferon gamma level, and then look for what's causing this, what's driving this. Was it an infection? Was it an autoimmune disease? Is it a cancer? And then treat that with the goal of it not coming back. And if it's genetic, which I think everyone should be tested that has HLH, treatments may be, like Nate, you had a bone marrow transplant, which may be able to cure it. And you want to do that before you build up these toxicities and this potentially even permanent end organ damage. So we talked a little bit about the diagnostic challenges. I think the symptoms that are often overlooked, I want to emphasize again, anyone with a persistent fever. You know, anyone can get a fever for a few days. That's probably not HLH. You might just have the flu or something. But if the fevers aren't going away and your blood counts are going down and your ferritin's going up, I think these are the things that you can use to advocate for family members or patients. And maybe checking something like a CXCL9, even though, you know, that's hopefully going to be more in vogue soon. I touched on treatment briefly. I want to expand on the treatments a little bit because the question comes up, what's the standard of care? What you do to treat these patients? And again, there's some absolutely fantastic pediatric HLH doctors, and they really figured this out in the very young children with sort of more classic primary HLH. Etoposide and steroids works really well, and they have this beautiful protocol for those patients. And it works really well for these very tiny babies with genetic HLH. And it almost all of them at this point in time, 100% uniformly fatal disease. Many of them can completely survive and make it to transplant. So potentially foolishly, because we're not all the same, and a 60-year-old is very different from a 2-month-old, we think that, oh, well, that works so good in kids, let's use it in our adults. And unfortunately, it's more complicated than that. So what my lab's goal of doing is every single HLH patient that we see exactly what's the cause, what's the driver, and we give them very specific tailored therapy to treat that underlying driver. And we sort of upfront, maybe the most urgent thing we now know is if the CXCL9 is high, it's almost easy. Give them imipalumab. I'll get to the access issues about availability of drugs and everything in a second, which is a huge problem too. But showing that this works, which was a little bit disputed, I think is a big first step. There's other therapies too, though. Etoposide is needed for some people. And we need to figure out which patients those are. And I think we're shedding some light on this. Zaref Lorenz and Mike Jordan have had a lot of recent data come out that if you have an underlying cancer or you're found to have an underlying cancer and you have HLH, actually etoposide could very well help. And combining it with your cancer therapy along with steroids will probably improve your survival. So learning these things sort of in piecemeal and trying to figure out exactly how to personalize this therapy for everyone. I sort of touched on the differences between the children and the adults, but I think the big unknown that so many of my patients ask when I see them, we're very good at getting them through the first point. Many of them in the past would die during that first severe HLH episode. We can keep them alive now, I think almost 100% of the time. And then the major question is, well, what now? Is this going to come back? Is this ever going to completely go away? How do we go from here? So I actually am pretty confident that the Hercules trial, which is my trial that we're running at the NIH, it's just a natural history trial. I say just because we're not doing a specific intervention, but I think these are sometimes the most important trials because we see patients with HLH and then we follow them. And we follow them for years, up to 5 years in the trial. And I'm going to try and make it longer in the future. They just made me cut it off at 5 years to get it approved because nobody knows these sort of relapse rates and will this come back. And this is really the most important thing to every patient. So we will be following everyone very closely and helping any way we can. If they live close by, we'll be seeing them very frequently, which we do for the local patients. Otherwise, we see the other ones a few times a year, or if things get worse, because this is something that, to be honest, when people ask me, I say, I don't know. But here's what I've seen in the hundreds or so of patients that we have so far. We're starting to learn. And hopefully next Histiocyte Society meeting next year, we're going to have our first report of that with some actual numbers. And I think it's going to be very helpful for physicians taking care of these patients across the country and the world. I want to talk a little bit about, I guess I did touch a little bit about connecting the science, bridging in the research, learning as much as we can about patients. I'll point out a couple stories that we've learned, maybe because I think I'm doing okay on time. The medical community had thought that classic genetic HLH can't happen in adults. And part of the Hercules protocol, we do whole genome sequencing on anyone. You have Nate and Anna Grace as great examples that it certainly doesn't only happen in very young kids. You can have genetic HLH at an older age. The oldest patient we have right now was 50, who was completely healthy his entire life, came in with acute HLH. Everyone told me that this can't be genetic, this has to be cancer. And he did not have a cancer. And we actually found that what he did have was classic genetic HLH. And we were able to prove that in the lab, give him a very specific personalized therapy. In fact, we found almost another 20 patients just like him just by looking. So I can only imagine this is in 2 years. How many will we find in the next 2 years? I imagine is going to increase exponentially. Patients with maybe one of the worst triggers you can have of HLH, EBV. EBV is the virus that causes mono. We all get it, but some of us get it and develop HLH. And again, many of them would die in that acute setting. They survive now. So the question of what happened afterward. And it was presumed as well that can never be genetic. People have looked here, there, and everywhere for genetic causes of predisposition to EBV HLH. Now, this is aside from XIP and the other XLP type 1 immune deficiency, which are very tightly intertwined. But we've actually found, which this will be coming out at some point in time in probably the next year or two, there are other genetic mutations that you can look for in these patients that actually we've been able to prove contribute to their HLH risk too. And the genetics are so important because if you can know your genetics and know who's at risk for it. Now, many of these patients may never get it, or many of these people may never get HLH because they're not patients if they never get it. But if you know that you're at risk, your doctors can at least be aware that if something weird happens, I need to call for help, or maybe I need to watch all of these people, children and adults, more closely. And I think we are making some strides in that too. Maybe the biggest problem still remains this access and equity issue because this knowledge, at least for now, is not widely disseminated. Our healthcare system, at least for now, is not built to really take care of rare disease patients. It's built to take care of the common things, but the rare things, when you really need multidisciplinary, you need every specialist talking to each other and then talking to HLH specialists. We're not good at that in the American healthcare system, mostly because people don't have access, also because there's not enough experts, and then also because even if you have an expert and they talk to the and they do everything perfectly and the drug that'll work, but the insurance company doesn't allow you to get it, or Medicaid won't pay for it, or you just lost Medicaid and the hospital won't pay for it. It's a very complex and difficult time. And I think there's a lot of ways that we can improve this, some through recognition, some through education, a lot through advocacy with pharmaceutical companies and Congress and helping, encourage, which you guys are the absolute experts on, and getting us some more resources to help patients with these rare, or I don't even like to call them rare, I like to call them uncommon diseases because they might not be that rare. We just don't look enough. And I'm hoping we'll be able to do these two things in tandem where we'll be able to increase access to these things. And if we bring the data and the receipts that shows that these things work, hopefully we can merge this together and improve outcomes for everyone in this country of all socioeconomic statuses. And then, or hopefully at the same time, we have some really great international collaborators all over the entire globe. And so just, I think to finish up here, so we can get to questions, looking towards the future, I think the future for HLH is really bright. I think there's a lot of great people working on it from the medical side, from the patient side, from the advocacy side with all of you guys. And I think we're about to make a number of huge breakthroughs. Some of the things that we're working on here that are about to open, we're starting 2 new. So we have our one natural history HLH study where our goal is to just bring you in, learn everything about you, and give you very specific personalized therapies that we have available. The next thing we're opening, probably within the next 2 months, is a brand new therapeutic treatment trial. You may have heard of it before. It's called ELA-026. It has a lot of potential. This is targeted towards secondary HLH in adults, although they're also looking at it in children. It's not FDA approved yet. Hopefully, this will be one of the pivotal trials that will make it FDA approved. And these are going to be open at, I think, over 35 centers across the country, and I think internationally as well. And I think this drug has a ton of promise. It's less toxicities than chemotherapy. It's extremely effective in the right patients, and I think it's going to be an absolutely essential tool to help people with HLH. Not long after that, I hope, optimistically, I'll say within the 6 months, I think we're aiming, and we're very close to this. I think we have the data now to say that if you could have HLH and your CXCL9 is high, emapalumab will work for you. I feel very confident in that. We talked to the pediatric experts across Cincinnati and Texas Children's and Philly and beyond. I think that's consistent with their experience too. And I think that we're going to have the data to prove that it works, and then we're going to run the trial to confirm it and make that drug available to everyone as well. Hopefully in less than 2 years, but we're really pushing that hard. So we're going to have new treatments, new tools. We have new diagnostics, and then we just need to, at the same time, improve recognition, improve education of physicians and clinicians all over the country and the world, and empower patients to advocate for themselves. I always tell Deanna and anyone else that if you hear about a patient that thinks they need help, just tell me and I will talk to their clinician. And actually, we've been able to enroll a number of the patients I've been connected with on Hercules, and we see them here if they're nearby a lot. If they're further away, we follow them once a year or as often as they can come. So spreading that advocacy and awareness and being there to help, that's what we're here for. And I'll probably end it there with a lot of excitement for the future. Very happy to answer any questions and very excited to have Anna Grace here to answer questions too.